offered in both residential and off-campus platforms. It was first offered off-campus mode in Cebu Institute of Medicine from 2004 to 2008, then in the Kingdom of Cambodia from 2012 to 2015. At that time, NTTC-HP was recognized as one of two of WHO's Regional Education Development Center in the health professions education in the Western Pacific region. In 2015, NTTC-HP's curriculum was again offered as off-campus mode in Cebu Institute of Medicine and Southwestern University, FINMA.
The National Teacher Training Center for the Health Professions is proud to have 7 heads of units from its foundation. They are the ones who greatly shaped the college over the years and give it its deserving prestige and platform. From 1 full-time and 2 part-time faculty members, NTTC-HP now has an impressive lineup of professors. The research extension and professional staff of NTTC-HP is also composed of 2 researchers and 2 library personnel. And there are 6 administrative staff. After 45 years, and true to the original World Health Organization mandate, NTTC-HP, through its alumni from different institutions, paved the way for the creation of 8 medical education units, namely UP College of Medicine, the University of Santo Tomas Faculty of Medicine and Surgery, the University of the East Ramon Magsaysay Memorial Medical Center, and Manila Central University in the National Capital Region, De La Salle Medical and Health Sciences Institutes in Luzon, Cebu Institute of Medicine, and the West Visayas State University College of Medicine in the Visayas and Davao Medical School Foundation, College of Medicine in Mindanao. In 2012, the Educational Development Centers for the Health Professions were also founded in the University of Health Sciences, Kingdom of Cambodia, and Lao People's Democratic Republic. The 21st century brings new and emerging roles for the present health professions educators. NTTC-HP responds by offering its revised outcome-based and blended learning postgraduate curriculum in 2020. The college will continue to offer relevant programs, conduct research and extension services that meet the challenges and gaps of the time in the Philippines and in the Western Pacific region. With all these trusts and accomplishments, NTTC-HP hopes to be recognized as a national center for excellence for teacher education and the World Health Organization's collaborating center in health professions education.
Good afternoon, everyone. Dami na tayo, no? Okay. So, please let me allow to start the lecture for today. Okay. Pleasant afternoon to everyone. I am Denise Peralta, your librarian of NTTC-HP. Our administrative officer, Ms. Beng Del Rosario, and I will be your MCs today. We would like to thank you for attending our second monthly seminar for this year. So far, we have 117 participants in Zoom, and some are joining us through the YouTube live stream. Again, before we start, we would like to remind you of some house rules. Okay, Ate Claire, can you please assist on the PowerPoint slides? Thank you. Okay, so while waiting for Ate Claire, I think, okay, thank you. Again, before we start, we would like to remind you of some house rules. Okay, first, kindly mute your mic and turn off your videos all throughout the presentation. You can type your questions in the chat box, and please do not record or take pictures of the slides without the permission of the resource person. The question and answer will follow after the presentation, and do not forget to accomplish the client satisfactory survey to have a copy of your certificate. You will receive a link for this later on. Next, please. We have applied for PRC Continuing Professional Development Units for the following professions. So that's 2.5 for nursing, 2 for licensed professional teacher, 1.75 for medicine, 1 for dentistry, 2.5 for pharmacy, and the CPD units for physical therapy will be announced later on. For other professions that is not mentioned, I think you have the option to apply it as self-directed learning. Towards the end of the seminar, Ma'am Beng, our admin officer, will discuss the details on how to obtain the credits for the seminar. Next slide, please. Okay, lastly, kindly edit your screen names in the following format shown on the screen. We would like to request everyone to follow the format that is given. So that's profession underscore your name. So for example, for LPT, for licensed professional teacher, that's LPT underscore your name. Okay, so that will help us later on to group you in breakout rooms. Okay, thank you. Our theme for this year is authentic assessment. Okay, I think someone raised their hand. Yes, ma'am. Okay, I think we can accommodate that later on. Thank you po. Okay, let us proceed. So our theme for this year is authentic assessment. So what is authentic assessment and how is this different from the assessment that we are familiar with? To give us the health system science framework assessment in health profession education is a full-time professor of the National Teacher Training Center for the Health Professions, University of the Philippines, Manila. So Dr. Erlene Sana obtained her doctoral degree on Philippine Studies at the University of the Philippines, Diliman. She is the immediate past dean of the NTTCHP and the current chair of the Office of the Research and Development. In 2001, the Philippine Medical Association awarded her the Exemplary Civilian Service to Philippine medicine. So without further ado, please let us all welcome Dr. Erlene Sana.
Good afternoon, everybody. Thank you for joining us in our March monthly seminar. For this particular session, I would like us or all of you to be able to explain the health system science as a third pillar in health professions education. You're all familiar with the first two pillars, and these are basic sciences, and the second is clinical sciences. I also would like you to distinguish the critical elements that determine authentic assessment, then share best practices where health system science is assessed authentically in both international and local settings. Yes, we have a good number of local experiences on health system science. This is not really actually new. Since the 70s, we have been doing health system science as well. And then the last one is for us to identify sample instruments to authentically assess selected learning outcomes in health system science. Let me start with telling you about the references that I use in this particular session. Many of you are familiar with these two publications from the Lancet and the Global Consensus for Social Accountability of Medical Schools. These two papers were commissioned separately in order to revisit the centenary of the Flexnerian curriculum. Okay, and then these two papers came up with some recommendations, and these recommendations served as basis for the succeeding papers that I am listing here. The 2009 World Health Organization, syempre ando na yun from the start, even before the Lancet and the GCSA. And then the recommendations from these two papers, as I've said, produced several articles on, for example, this article on realizing the vision of the Lancet Commission on the education of health professionals for the 21st century by Skochelak, Lomis, et al. And then by Borkan, Hamod, and Nelson, and et al. On the health system science education, the new post-Flexner professionalism for the 21st century. Aside from the health system science, you will also be familiar with authentic assessment, which is our theme for this school year. So I'm sharing also the Asford, Rowe, Harrington, and Brown article establishing the critical elements that determine authentic assessment, Cumming and Maxwell, contextualizing assessment, authentic assessment, and in the local, as our local reference, we mentioned this several times already, the Joint Administrative Order of the Department of Health, Professional Regulation Commission, and CHED, which followed after the release of the Republic Act 11223 or the Universal Healthcare Law. Okay, so I would like to start with the statement of the problem. This was produced or written by French and Buta et al. In the Lancet and as well as the GCSA. The two papers revisited, evaluated the curricula in the different fields in the health sciences and came up with conclusions including that there are still glaring gaps and striking inequities in health that persist between and within countries. Poor people in developing countries continue to still have common infections, malnutrition, maternity-related health risks, which have long been controlled in more affluent populations. And in many, many words, citing different examples of countries, these two articles came up with the conclusion that there's a mismatch of professional competencies to patient and population priorities because of fragmentary, outdated, static curricula producing all equipped graduates from underfinanced institutions. So we talk here of health sciences schools, and then over the last 100 years, we're not able to address the basic population health problems of countries. And in response to this statement of the problem, the two French and Buta et al. Article presented and reviewed the systems framework where health science education comes in. So in this model, we have two systems: the health system representing the demand side for human resource for health, the Department of Health and all those industries, agencies are the ones that recruit our human resource for health. It is the responsibility of the health system to capacitate itself with competent and adequate number of human resources for health. And that's the job, the provision of the human resources for health for the health system to function and operate is the job of the school system. And so we have the educational system that represents the supply side of our health workforce, and they have to be constantly aware of what our population health needs are so that whatever the school teaches will be exactly what the health systems will recruit. So if we talk of HRH for the health system, we talk of health sciences schools representing the educational system. And the activities of both should be focused on the same thing, okay? The same thing is, the problem is, based on the two publications that I have mentioned, the schools were not able to meet the population health problems of different countries. And so education in the health sciences, especially in medicine, only became longer and more expensive, but still failed to solve the major or the common population problems of the world. And in response to that, in the year after, the World Health Organization called for a transformative scale-up of the education of health professionals. The WHO defined the transformative scale-up of the education of health professionals to be driven and informed by population health needs. Transformative scale-up means delivering educational reforms that address not only the quantity, but also the quality and relevance of healthcare providers in order to achieve improvements in population health outcomes. I highlighted here the QQR because the schools, remember, represent the supply side of our human resource for health market, and the schools are mandated to produce a good enough number of health professionals to help the societies and countries to address their population health problems. But other than the number, the schools are also mandated to produce competent professionals in terms of quality, and that they should be able to exercise these competencies in the places and geographic areas where they would be needed. So that's the meaning of our QQR. In 2013, the WHO clarified the meaning of the transformative scale-up into the sustainable expansion and reform of health professionals' education and training to increase again the quantity, quality, and relevance of health professionals, and in so doing, strengthen the country health systems and improve population health outcomes. So this is a big challenge for the health sciences schools to be primarily grounded on population health problems that should be the basis in the training and formal education of our future health human resource for health. Okay, so there's a call that was done by the WHO, and in response to this evaluation review of the flexitarian curriculum, Frank Chen Buta et al. Came up with this recommendation for reforms. This is especially addressed to health sciences schools. There are two categories of reforms, beginning with instructional. So this refers to the teachers, to the course designers, and to those who are actually delivering instruction in the classroom. That they have to be competency driven. They recommended competency-based / outcome-based education. The curriculum that must be taught in schools should be reflections of interprofessional professional education. It should be IT empowered. So take note that even, I think in the early discussions we had with outcome-based, I mentioned that since 1994, SPADE has already been calling for the integration of technology in health science education. And again, in 2010, Frank Chen Buta et al. Called for the IT-empowered health science education. Design of courses should demonstrate both local and global contexts. There should be a good number of educational resources or open educational resources that should be used as materials for instruction. And in the long run, there should be professionals who are trained with new kind of professionalism. That is a team. We're referring here of a team of health professionals who are able to work collaboratively and are able to maximize both local and global materials for instruction. Okay, but this is as far as the teachers, the designers are concerned. They cannot do any relevant reforms in their courses unless there is a corresponding institutional reform. And this is from the side of the school administrators and academic leaders. That for the real transformative scale-up of courses to take place, there must be joint planning. And in joint planning, this means planning of the schools, meeting with the students, their parents, and the consumers of our products. And this refers to the health sector, the health system, the Department of Health, the different industries that require, the hospitals, all those facilities that will require human resource for health. This is a signal that if we are not teaching if our students are teaching a different set of competencies that are not in the joint planning, then that means that there is likely to be a mismatch. The institutional reform also calls for academic systems. So we talk about universities, schools, and institutions that function not just as mere schools, but are partnering with industries, partnering with communities and civil societies, so that the whole one roof of the school represents a microcosm of all these other institutions of society. The health sciences schools should also be working with global networks so that there is a sort of there is an internationalization of the quality of education. There has to be these schools must be able to meet certain international standards so that there's confidence in the kind of products that we produce. At the heart of this institutional reform is the inculcation of the culture of critical inquiry. Because remember, side by side with this reform was the call for international qualifications referencing, so that wherever the professionals practice in different countries, there will be the same quality of professionals in terms of competencies. And we can only produce that kind of professionals if they have been honed in schools culturally as problem solvers, critical thinkers, and used to engaging in higher order thinking skills. Okay, this was a call that we have we started to advocate for since 2010 when the Lancet article was published. And towards this, to be able to carry out these reforms, Frank Chen Buta et al. Identified enabling actions, and these include, of course, mobilizing leadership. And leadership here doesn't just mean the school's administration, okay? It has to be a whole system of leaders from the different institutions like the Department of Health, our health sciences schools, the Commission on Higher Education, PRC. And then enhance investments, aligning accreditation, and strengthening global learning. I have explained earlier that in the institutional and instructional reforms, there must be a need for investments. There has to be some financing that has to take place so that the underfinanced schools will be given new fresh starts of resources, facilities, even the hiring of the more competent faculty members and administrative staff. And to ensure that quality is being maintained, the schools are challenged, and actually it's a strong recommendation that the schools work for accreditation. The goal is to achieve transformative and interdependent professional education for equity in health. So if we will be able to achieve this or work towards these recommendations, we expect that we will be able to achieve this vision for a new era of professional education where there is equity in health. The individuals and the populations are the health problems of both individuals and populations and communities will be addressed adequately and competently because they are produced by schools that engage their students in transformative learning, interdependence in education. It's a new kind of professionalism, and so we see here, we anticipate here in this vision that the human resource for health that we will produce will be those that are conscious of the entire system. And so you see the connection between the 2010 article recommending the teaching of health system science or HSS. Okay, so what is or how this article was published in the US, and so I'm starting with the discussion on how the United States responded to the global call for transformative learning in HPEd. Scotchelak Lomis et al. Introduced the American Medical Association Accelerating Change in Medical Education Initiative. This was assembled by AMA in 2013 in response to the two articles that we have been talking about. After 2010, there were a series of consultations with the different sectors conducted by AMA, and they came up with HSS in 2013. They developed the health system science curriculum, and it was piloted in 11 schools, initially with $1 million grant each school. They called for a competitive, AMA called for a competitive submission of proposals, and there were 80 proposals received by ALMA, showing that it was valued but the funding was limited to 11 schools. And later on, over the years, new grants were released. And at present, the HSS, the Health System Science curriculum, is now being carried out in 37 out of 155 medical schools in the US. Okay? And the health system science, as I've mentioned to you earlier, is a result of this recommendation challenging the traditional Flexnerian curriculum where we have the two pillars, the basic sciences and the clinical sciences. And then after the first 4 years or so, the students are allowed to go to clinical practice in form of internship or practicum or clerkship. This kind of education, according to the health system science framework, is the usual is equated into the kind of healthcare that we have for the longest time. The kind of healthcare that deals with population problems in an acute way. We interpret all these problems as acute conditions. There is one patient and one physician, and then the setting takes place only in the clinic. This Flexnerian curriculum, based on the two pillars, are actually responsible for the kind of healthcare that we have for many years. And so it's hospital-based, it's clinic-based, and it's dependent on the physician. There is a medicalization of the entire healthcare system. This is the one that's being challenged by the health system science framework, so that the care or the healthcare system will move towards dealing with problems as chronic, pero because the problems continue naman to remain in the family, in the community, in the world, but this requires a team to work and to address the problem. It's not dependent on one problem of the patient, but it's looking at the bigger picture of the population, of the health of the population. And so the approach is to look at the health problem in the context of a community, a group of people or family that is experiencing the condition, and that can only be solved by a group of people, not just the health science professionals, but the other members of the community. Okay, so because of this weakness in the setup in the Flexnerian curriculum, the health system science was introduced, and this is the AMA health system science framework calls this the third pillar. Borkan Hamod et al. Presents this AMA creation on the health system science. What do you see here? At the center of the wheel is the driving motivation, which are referring to the patient, the family, and the community. So at the heart of the wheel is the patient, his family, the community. What are their health needs? What conditions do they live in? What are their determinants of health? What are their seeking behavior? And what are the common conditions that they encounter with respect to their health? This must be our foundation. So all health system science begins with epidemiology, with the studies of the burden of disease, the mortality, morbidity patterns, okay? And using this as the driving motivation to guide the 6 foundational learning areas, namely healthcare structure and process, health system improvement, value in healthcare, population, public and social determinants of health, clinical informatics and health technology, and healthcare policy and economics. So you see here, when we are talking of health system science, we are not just talking of the clinical subjects. We're not just talking of the basic and the clinical sciences that should be in the different health degree programs that we offer. They are the topics, the sciences are just one part, just one of the learning area. So we talk here, for example, of the value in healthcare. So here we talk of those disciplines related to health, the anatomy, all those other sciences, but in the context of population, public, and family community problems. Okay, and it makes use of the ICT, the information and communication technology. And so with the guidance, with the motivation provided by the patient population and community problems and health issues, the courses will be designed according to these 6 foundational learning areas, but as are also uh, cross-cutting into the 4 domains, namely teaming. Okay, so the first major feature that we have to remember in the health system science is that it requires a kind of teamwork among our health professions students. In the different programs in the health system science, there must be opportunities where the students will learn about their basic and clinical sciences here in the foundational areas, number 3 and number 2, but in the context of a team, a group of partners working professionally and interprofessionally. Okay, and after that teaming, we have number 2, cross-cutting domain. This is referring to change agency and management and advocacy. So the institutions of government, the health department, all other agencies should be advocating for change, and this should not be difficult because this will always be dependent on the sciences and as they are experienced by our people. Okay, and then the third cross-cutting domain are ethics and legal standards. The professions in health are regulated by these standards, and so they should always be pervading these foundational areas and domains. The last one, of course, is leadership, because the students have to appreciate that a health system science cannot proceed without a mandate from the people who are mandated to implement reforms. The health system science framework is surrounded by the outer spoke, referring to systems thinking. And we see here that no topics, no subjects in the health system science should be taught or should be designed without the context of systems thinking. Borkan, Hamad et al., and the AMA itself calls the products of health system science as systems citizens. Okay, that they are not expected to deliver care or take care of their patients or their families or their communities single-handedly. It should always be with a team. It should always be within the systems, within the existing structures. Okay, and so how do these pilot medical schools carry out the health system science curriculum? I'm going to cite 2 experiences of the Warren Alpert Medical School of Brown University. It doesn't mean that the entire course, the entire curriculum will only change one subject. Okay, the health system science in Warren Alpert in Brown University has health system science courses required for all medical students beginning first year. And these health system science courses are integrated in the medical subjects. the courses have new have innovations in terms of approach. There is a navigator program referring to the students who are given responsibilities to work with experts, to work with different groups of professionals, so that they are in the process able to explore and navigate how the other systems work. They engage in free clinics. They render services in the home in homeless care, and so as early as first year, second, and then it goes all the way to third year and second year and third year. They are exposed to the different levels of the health systems and are expected to also assume different levels of accountability. Okay. uh, there is a longitudinal integrated clerkship or LIC program with integrated HSS didactics, and there's an additional research course with the thesis requirement related, the topic of which should be related to health system science. Okay, so this is one example of the real experience of Brown University. The Mayo Clinic Alex School of Medicine requires 4-year longitudinal course in HSS, the Science of Healthcare Delivery, on its 2 campuses in Minnesota and Arizona. It has 6 HSS-related domains, the ones that I have explained earlier, and the faculty use flipped classroom, simulation, experiential education strategies, and provide formative assessments as the students apply concepts and skills. This pretty much the same as what we are doing in many of our health sciences schools in the country. But of course, the focus are the learning domains inspired, motivated by population centered care, family health, and community health problems. Okay, how about the health professions education in the Philippines? How did we respond to the global call for transformative learning? As early as 2012, CHED has already ordered or released the Memorandum Order 46. This is calling for health sciences schools to adopt or transition to outcome-based education and OBE typology quality assurance framework. And then a year after that, the Commission issued CMO 20 series of 2013, referring to general education curriculum, which teaches about holistic understandings, intellectual and civic competencies. NTTC is currently working on NTTC is the only college outside College of Arts and Sciences in UP Manila with a GE course. We have HPED 20, Learning for Teaching, and we are completing our research project this week. And we are hoping that there is going to be a reflection of HSS in that GE course. That was institutionalized in NTTC in 2010, but had its maiden offering in 2011. And then after 2013, there were succeeding CMOs, policies, standards, and guidelines in the different degree programs in the health sciences. I think many of you should all be familiar with the appropriate CMO that is regulating your profession. Okay, the features of CMO are the same from 1 to 9, from introduction to authority to operate, general provisions, program specifications, curriculum, required sources, and you will see here, if you revisit your CMOs, I'm citing, for example, CMO 18, series of 2016, which is referring to the policies, standards, and guidelines for the Doctor of Medicine degree. There, in the program specification of CMO 18, there are 10 program outcomes in medicine. And you see number 1, number 2, okay, number 3, they all will require students to interact with people, with different kinds of professionals, with different kinds of sectors. And then there is number 4, number 5, number 6 is utilize systems-based approach to healthcare. So, and then you cannot teach systems-based unless you are ethical, unless you are guided by your professional legal standards, and at the same time becoming socially accountable. So the whole set of program outcomes in medicine alone is already reflective of this consciousness of the health system science. Well, that the term HSS came from the US, but we would like to say and declare that we have responded already actively in the call to the transformative scale up of the health professions as in almost the same year that the call was made in 2010. Okay. After 2013, that's the GE CMO, and then came the first in the health sciences that was released was for medicine in CMO in 2016. All the other professions in health followed. So we have CMOs in 2017 and 2018, and then the last one I think was in 2019. Okay. So in the National Teacher Training Center for the Health Professions, we have actually responded to this call towards transformative learning. And in fact, since 2015, we have been revising our curriculum, and finally, the University Council of UP Manila approved our two new tracks in our master's degree program. We have the MHPED, the professional track, and the Master of Arts in the Health Professions Education, the academic track. These are both 30 units. The MAPED has a thesis requirement, while in the MHPED, you have a capstone project. We have already the Doctor of Health Professions Education degree program starting 2020, and all of these curricular offerings have subjects related to health system science. It has interprofessional and collaborative practice course. We have foundation subjects related to philosophical foundations of education. We have community-based planning, and all of these courses, we hope, are actually focusing on health system science. Okay. We are also, specifically in the case of HPN, we are supporting the co-producing health professions education perspective in terms of engineering our teachers in the health sciences as pictures of this model. So from the original health system science, we see here the community and society and covering the healthcare system, okay? And then there are patients and professionals. There is co-execution, co-planning, civil disclosure, so that we achieve good health for all. This is as far as healthcare delivery system is concerned. Putting it or juxtaposing it in the context of health professions education, where school system prepare health professionals to teach, we are equating the patients as learners and the teachers as the professionals. So we are the teachers, the health professions educators, and so this includes the families, the health professionals, this includes all of us, and we are together learning within this context of the health system, so that in the end, we remain partners, we co-execute, we co-plan, we engage in civil discourse, and the outcome are our graduates are human resources for health, or HRH, who co-produce healthcare. Before, HPED was detached. I myself am a witness of this. I'm a witness of this kind of disconnect. that our teachers are trained on the principles of education, our students are trained to develop courses, to evaluate programs in education, to do educational leadership and management, and we weren't very conscious of the health problems outside our domain. But we are responding to this global call for transformative scale up so that even in HP Ed courses, we already talk of health system science, we talk of sustainable development goals, because in the whole picture of things, we want to be contributory to the co-production of healthcare. Okay? So I'm saying the health system science has been with us since 2010. Theoretically, I mean, in the real sense at least, okay? Even if we're just introducing the concept of health system science more recently. Okay, there are other responses in the field of family and community medicine. The Philippine Academy of Family Physicians has already established 2 tracks of residency training. By the way, the call for health system science is expected to pervade not just the undergraduate program, but also the postgraduate program. So in this case, we have the Philippine Academy of Family Physicians already implementing its 2-track programs. One is hospital-based, the usual hospital-based residency training program, and the other one is practice-based program adopted in 2019. And you see in the professional roles set by this program, the residents, the family physician practitioners are expected to perform complex roles. Before, they were just expected to become healthcare providers. That's the result of the traditional Flexnerian program. But here in this transformative program, they are expected not just to be clinicians, but also educator, researcher, coordinator, navigator ule, and leader. So because of these complex roles, you cannot afford not to study and have a good grasp of health systems science. Okay, so I think at this point it is now important to talk about, so what's health system science? This comes from the health system framework. And when we talk of the health systems, however you call it, it will always be composed of the 6 system building blocks, namely service delivery. So this is how the healthcare service delivery is structured. In the Philippines, for example, we have the rural health unit, the primary level of care, to the tertiary, the district hospital, and then we have the interlocal health zone, and all the way to the tertiary level of care. In each of these levels of care is a corresponding human workforce, or the HRH. What kind of professionals do we produce? What are their competencies? How many are they? So it goes back to the QQR, remember? The healthcare system cannot function without information, and assumed today is that this information should be electronic. And of course, they should not be tampered, they should be valid, accurate data. Okay? The other building block is medical products, vaccines, and technologies. I think this doesn't need any explanation, including financing, leadership, and governance. If all of these system building blocks are working together in synchrony and synergy, then we expect improved health responsiveness of our healthcare system that will not give us too much financial trouble. And it should be efficient. With the kind of crisis that we have already experienced before and the ones that we are experiencing right now, we know that health systems can be challenging. Maintaining the health system to work effectively is challenging. Okay, this time I'm showing to you a framework developed by the Human Resource for Health, specifically from the Department of Health. This was a part of the Joint Administrative Order 2021-0001. The whole picture of promoting or integrating health system
Yung unang gate
science
sa kanan.
in
Ito na.
our programs in health will eventually be just the practice of primary care. Okay? And in the Joint Memorandum Order, all health sciences schools are mandated to train or educate their students from the undergrad to postgrad level primary care approach. Okay? What I'm showing you here are essentially the building blocks of health systems. They're just called a little differently. Yung level of care, so this is the health services. Okay? Yung service delivery, sila pa din yon. Health services, financing, syempre leadership and governance, from the public to the personal, from the patient to individual patient to the community level. And the overall approach is that of primary health care. How old is primary health care? This was introduced in 1978 during the Alma Ata Conference, but UP, the School of Health Sciences were already introduced in 1975. So it's the SHS has been practicing primary health care since 1975. It's 3 years older than Alma Ata. So we equate now health system science to primary care approach. Okay? I'm showing you pictures of how we experience the health systems crisis in our country. So this shows the problem of human resource for health, the healthcare service delivery system. Okay. These are workers wearing COVID-19 protective gear, using a stretcher to bring a body bag. This is in Baesa Crematorium in Quezon City. This was at the time that there's a shortage of crematorium already. So in the end, diba, we experienced just burning all those dead bodies almost indiscriminately, just like in India, kasi we didn't have any more facilities. Okay, there's another instance here where health co-workers in the National Kidney and Transplant Institute staged a protest, and this is a crisis again of human resource for health. Okay, as we are continuously in the pandemic, there is again value in revisiting the primary care provider competencies, and this is again stipulated in the Joint Memorandum Order that our workers in the professions of health should be primarily primary care providers. They should be equipped and fully capacitated to render primary care services, but should also be able to do laboratory medicines at primary and secondary and doing inpatient referral. So, pabalik pa din yan sa health system science, okay? At syempre, sa crisis that we're experiencing now, lagi tayong tumitingin sa ating health information, sa ating data. I'm showing you a picture of New Zealand, one of the best and most efficient healthcare delivery system in the world. Pero, kita natin with the coming of the Omicron variant, eto na lumabas. New Zealand has only 5 million population. Meron na silang 500,000 confirmed cases. Last year, the death only was pegged at 25. Now it's 201. Imagine the health crisis that's going to take place if this is not contained. So, sabi nga ni Dr. Tedros Adhanom Ghebreyesus of the WHO, the world needs to work together not only to respond to COVID-19 but to build back better and ensure we emerge with stronger and more resilient health systems. So the call was made in 2010. The curriculum was developed in 2013. With the coming of this pandemic, there is more reason to teach everybody in the health science professions health system science. Okay? So, there are challenges in implementing health system science. Again, Borkan Hamad et al. Enumerated them as 7, and there are corresponding measures already being done here in the US. These are comprehensive, standardized, integrated curricula. How can you do this in such a short time? Okay. The last thing that you want to change in any health sciences school is the curriculum. And then with the change in the curriculum comes the faculty knowledge. How comfortable are they teaching health system science? Trainee receptivity. The students themselves also. How receptive are they to studying health system science? And then there's a big effect on the hidden curriculum. Those things that we do not teach, but we role model, they are even dangerous than the official curriculum. We have challenge in the buy-in and alignment of HSS within the health systems. Okay, this is very clear, I think. Competency assessments across education curriculum. We talk of assessment in a short while. And the value added to system and student education. Because this can mean, at the start, this can mean additional subjects, additional courses, additional preparations, and additional expense. Okay? But these challenges are not new to the Philippines, and we are doing a series of capacity building programs and investments in order to come up with this effective, efficient teaching of health system science. So in the end, we talk of health system science, as I've mentioned before, the outcome should be system citizen citizens who engage in systems thinking. And at this point, I will just show you 3 of the final outcomes, learning outcomes of products in health, of graduates in the health system science curriculum. They should be able to take one's position within the context of the larger health system and practicing in a manner that's team-based, collaborative, and attuned to the health system science issues. Okay? So this is a different expression of a learning outcome, but there's still a verb. There's still a noun. Okay? You take one's position. The students should be able to understand the interdependency of all components of health, of care delivery, and view themselves as stewards of that health system. So you cannot be on your own. The last is contribute to continuous evolution of the healthcare system itself to help achieve optimal results for patients and populations. Because this emanated from the American Medical Association, of course, the output expected are professional identity of physicians or health professionals who are embracing system citizenship. Okay. Now that we have understood, I hope, understood the health system science framework, the next question is, how do you assess authentically these outcomes? Okay, I would like to review from what NEM has discussed from January. Authentic assessment is engaging and worthy problems or questions of importance. These are authentic assessments are engaging and worthy problems or questions of importance, in which the students must use knowledge to fashion performances effectively and creatively. The tasks are either replicas of or analogous to the kinds of problems faced by adult citizens and consumers or professionals in the field. This was introduced by Wiggins in 1993, and we can see here that authentic assessment is beyond a written exam. These are questions, problems that will require students to make use of their knowledge and produce an output. So this is performance assessment. Okay? What are the distinctions between the traditional assessment and authentic assessment? This is exactly the same as the Miller's Pyramid, the one that we use in outcome-based assessment. It's workplace-based assessment because authentic assessment, or AA, engages the students to perform a task in real-life setting. There is construction or application, there's transfer of knowledge from the training to the workplace application. It is student structured because it's the student who will do the performance, and they should produce direct evidence. Okay, I'm going to explain this time the elements of authentic assessment. The first one is authentic assessment should be challenging. It should be a task that establishes connections between real world and school based ideas. The challenge of constructing or producing meaning or knowledge instead of just reproducing. Reproducing is rote, it's recall, it's remembering, and it's lower order thinking skill. So, in the case, for example, of Republic Act 11223, requiring all human resource for health to be capacitated with basic life support and disaster risk reduction management. This is a new competency required of all teachers in the health sciences. So, if we're doing capacity building on DRRM for R&D faculty, these are registered nutritionists and dietitians faculty, an authentic assessment will be, for example, for them to formulate a disaster risk and reduction meal plan at the emergency evacuation site. We experience several emergencies many times in the year, and time again, we see instant noodles being served to people. There is infant formula served to infants, and they are not even separated from. They do not even stay in a separate place in the evacuation center. So you want authentic assessment that they know basic life support and disaster risk reduction management. We train these nutritionists and dietitians to be active members of our disaster reduction team. Okay? Second, authentic assessment should be in the form of a performance or product. So the output is not a recreation of the lesson of the concept. It should be able to demonstrate skills and knowledge by engaging in a complex performance, creating significant product or accomplishing a complex task using, as I've mentioned, higher order thinking skill and problem solving and creativity. I am going to cite to you one of our most esteemed graduate. Dr. Ramon Arcadio was our student in the MHPED program. He graduated in 1990. So he started his courses with HP 211, its curriculum planning and development. Dr. Arcadio conducted the needs assessment of students. His students are residents. What is it that the students need if they need to be practicing pediatrician? So he did a needs assessment. So one of the key knowledge in curriculum planning. But he made use of this needs assessment and identified the need for further training of pediatricians in ambulatory pediatrics. And so he developed his project in MHPED is the pilot fellowship program. It's the design of the fellowship program in ambulatory pediatrics. It required competencies in doing needs assessment and designing curriculum, which will include formulation of educational intents, choosing the right strategies for particular learning outcome, assessment, and assigning students into the different areas, clinical areas, to be able to become good ambulatory pediatrician. This was 1990. Fast forward to the present, this program is the fellowship program in ambulatory pediatrics institutionalized at the Philippine Pediatric Society. What is the meaning of this? What does it have to do with authentic assessment? If you assess authentically your students and make them produce outputs as reflections of what they learned about the course, there's a chance, of course, that they will take it personally. They will take it to heart. So they will not submit anything just for the sake of submission. And this plant This seed that was planted in the 90s has now blossomed in the full ambulatory pediatrics curriculum. And of course, I would like to show you our dear Chancellor, who, after that ambulatory pediatrics curriculum, when he rose from the rank from the faculty of the Department of Pediatrics to becoming chair, college secretary, and dean, eventually the Chancellor of UP Manila, he has pioneered and carried with him this knowledge, competencies in the master's degree program of NTTC. He pioneered the UP College of Medicine and the country's one and only organ system integrated curriculum. He has spearheaded the expansion of the UP Manila School of Health Sciences in 2 campuses in Coronadal in South Cotabato and Baler, Aurora. He championed the voluntary accreditation of med schools and designed and implemented the 2-track residency and fellowship programs. I'm saying that even in health professions education, we have a system that can merge with the health systems. And if you're conscious of engaging your target learners, your target end users, like the schools and the hospitals and the different professional societies, you will be producing more and more products because of how you have confidently created the first during your authentic assessment. Okay? Oh, thank you, Chancellor. The third one is that authentic assessment should ensure transfer of knowledge. It's, again, using the 2 examples that we have cited already, in assessing students' competence, for example, in history taking, communication skills, evidence-based practice, and charting, chart ang kukunin mo. But you collect the charts of interns based on the patient seen, for example, by telemedicine. Tingnan nyo, what are reflective skills in history taking, communication skills, or evidence-based practice, and the patient seen by telemedicine. So you see again the 6 foundational areas and the domains that are cutting across, and the output that you are looking are the charts. Metacognition is a component of authentic assessment. Metacognition establishes the value and importance of both critical reflection and self-evaluation for successful workplace performance as well as personal development. If an authentic assessment has a built-in character of metacognition, then the students should be able to determine their strengths and weaknesses, what areas they need to improve on. I'm citing a real example. The patient here is my mother. A small group of third-year medical students assigned to present a real case from the ER records. So there's an ER record. Cases of an elderly patient bitten by a cat and goes to the ER regularly for anti-rabies shots. I think my mother and I went to that hospital, to that ER, 15 times ba? Hindi ko na maalala. Pero yun. So, and each time we encounter a group of third-year medical students who do the history, and then later on they are referred to the residents for the injection. The preceptor noted that the group researched on rabies, how to manage it, especially in the community setting. I don't think their rabies and the snake bites, those common community emergencies, are taught formally in med schools. But because there's a metacognitive component of their experience in the ER, the students appreciated that feedback. Kasi pinuri sila ng preceptor, and they continue to make infographics on preventing common community emergencies. Okay? So there has to be room for metacognition or self-examination in authentic assessment. Authentic assessment gives value to the requirement to ensure accuracy in the assessment of performance. Minsan kasi, the assignments that we ask them to do is just pass and fail. Sometimes teachers do not even bother to read them. The problem is hindi natin nakikita yung accuracy ng product with respect to the outcome that we set. This number five element is two-dimensional. The first is to establish the extent of the learner's intellectual input in the development of the product or performance to check the authenticity reflected in the output. If the output is a performance, I have an example pala that will follow. The authentic assessment in the second dimension seeks to determine how central assessed skills and knowledge are to the work-related application. If we have authentic assessment outputs or requirement, let's make sure that they do not just produce for the sake of producing. It should be a reflection of what are the central skills that we are assessing, and that we should be careful of camouflage outputs. Okay? Yung camouflage outputs, teka, andito pa yun? 5? Oh yeah. Ang camouflage outputs, eto nakita. A class of dentistry students have been divided into small groups and engaged in a flipped classroom activity. The task is to formulate a management plan for a pediatric patient with poor oral health habits and her deciduous teeth are already falling off. Okay? Ang authentic assessment, syempre, ano lang yon, management plan lang yon. They did a flipped classroom activity. And during the plenary presentation of the small group discussion outputs, the class was impressed with the multimedia production of one group. As in, naka-video recorded pa siya. Okay? So you can immediately be impressed because it's a multimedia production rather than just a presentation using PowerPoint. But the professor appreciated the media, but emphasized that the main task remains the primary basis of assessment, and that's the management plan. Okay? So let's not camouflage the output. We may be impressed with the way it is prepared, but the point is we are still looking for the central skill that should be the first basis of assessment. The last one is authentic assessment gives value to the role of the assessment environment and the tools used to deliver the assessment task, especially in the present situation that there is COVID-19 going on pa din. If a real-world environment is difficult to be recreated, in a training environment, from the real world, nasa training environment pa lang tayo, the extent of assimilation required to accommodate the assessment has to be determined. Okay? The output may include broader cultural elements such as language, cultural practices na lang, kasi simulated pa rin siya. Okay? Like in the case of vital signs monitoring and physical diagnosis, as well as student to family members, administration of local anesthesia in an oral surgery class. This is a long sentence, but this is a case of the second year oral surgery class who should demonstrate already proficiency in administering local anesthesia. Because the students couldn't meet the class face-to-face, the plan for authentic assessment done by our student here, who is the teacher in surgery, was to make the students make use of their family members as their patients. So they have to submit a logbook to describe the vital signs monitoring, oral examination, physical diagnosis, and administration of the local anesthesia. And then the language, the rapport that they have to present, because they need to submit the video of how they did this. So there is this environment of assessment that has to be there, even the closest possible way. Okay? The seventh pala is the last. Authentic assessment design includes opportunities to discuss and provide feedback. There is no performance assessment that's real and authentic if there's no feedback. It's no longer true that practice makes perfect. Practice and performance without feedback will not make a perfect output. The students have to know and there should be constructive and timely feedback. It's crucial to determine areas of improvement for students to be guided. Okay? So when you design authentic assessment, the overall philosophy is you know your learning outcomes, you know your learning scenario, and then based on these learning outcomes, you make the students produce real products, real outputs, evidence that they have indeed learned. It is beyond a written exam. Okay? So this time I will be stopping my session and I will discuss with you during the break after the question and answer, the nature of our breakout rooms. Okay?
Denise?
Yes, ma'am. Okay, I'll be sharing this.
Erlyn,
Yes,
wait. Erlyn, I saw Dr. Arcadio there. So, pwede bang, para lang makita natin, and we just,
Nahanap ko nga
Sir.
eh.
nandiyan nakita ko eh. Sir, pwede ka bang para lang magkaroon ng face yung ating discussion kanina. Sana si Sir. Sir, pwede ka bang mag-show ng yung video, mag-on ng video? Nasaan na yun? Ang dami kasing panel, di ko na tuloy mahanap. Sige, mamaya na nga lang.
Hindi ko pa rin nakikita si Chansey. 200 pala. 223 pala tayo ngayon.
Oo. Makita sa 9 bang pa? 9 kasi tayong pages eh. Yes, while you can write your questions on the chat box. Ang daming ang tao. Dr. Alfareta Reyes is also here with us.
Hi, ma'am.
From students and alumni. Si JC. Siyempre, kaisa-isa kong kapatid, narito din. Nasa doon yun.
Nakita ko si Dr. Lago.
Oh.
Dr. Lago, yung nanay ko po, yung nagkita tayo sa ER na kasama ko, yan, ang istorya nung sinasabi ko sa inyong, mali yung spelling ko ng beat.
Binugbog ng pusa.
Binugbog ng pusa.
Lang yan, nag-autocorrect.
Kinagot lang pusa ng pusa. Okay, so I can entertain a few questions before we go to the breakout rooms.
Yeah.
Yes, for those who have questions before we go to breakout
Wala si
rooms, you can
Chansey.
type in sa chat box or raise your virtual hand.
Nakakatakot yung walang imik.
Oh.
Two things. Naintindihan lahat. Oh.
Yan, meron.
Message po tayo. Okay. So, please let me read po the question by Ma'am Ana Karenina. So, with regard virtual skills demonstration, would it be prudent for us to choose skills that would not entail risk to the standardized patient that the students must use?
Yes. Yes, Karen. For the time being, we hope that it will still be temporary, that the students can still make use of virtual skills demonstration, or I understand that some schools have already started their limited face-to-face, but the arrangements done for skills acquisition is such that the students go to the lab, or the students go to meet a standardized patient, and they remain there for the skills build up. Meaning, the students are assigned their specific time and specific patients, so that the exposure is minimized. That can already be arranged. It's a little expensive, a little laborious, but it's being done now. I understand that yung mga small, before, di ba, the skills laboratory is finite as that one fixed place. But because there are no classes naman going on, some schools, like in UP, there are classrooms that have been renovated, rearranged in such a way that several students will be meeting their patients during their specific periods of time and not be able to chat. And that's only arranged for skills acquisition outcome.
Okay, thank you, Ma'am Erlene. So, sa chat box din po, no, nag-reply din po si Ma'am Ana Karenina, and she mentioned that they do it now doon po sa kanila.
Oh,
Kanilang
di ba?
institution.
Thank
Okay.
you. Mm-mm.
Okay, so we'll read another question from Ma'am Sheila Trajera. So, among the authentic assessments which you have introduced in your class, which do you think is the best?
Ako po yun. Ay, ayun na si Chansey.
Yes.
Nagtago. Chansey. Thank you. Teka muna, Dr. Traera. Pinapakita ko muna si Chansey. Ito ang aming best example of authentic assessment. Thank you po for honoring us with your presence.
I didn't know that you will call me.
Nag-text po ako, baka kasi magulat kayo bakit po dinala rito si Chansey. I had to inform him that I will be citing his works in this discussion, kaya salamat po sa pagpapaunlak, pagsama sa amin dito. Yun. So, meron ba kayong update dun sa inyong mga inventions na curriculum? Lahat yun ay...
Hanggang sa APNC, di ba? Kasama natin si Chansey.
Ang gusto ko lang sabihin, ang pangalan ng fellowship training program namin ay Academic Fellowship Training Program. It is the only fellowship program in the Philippines that is named Academic Fellowship Program. It is the only program where fellows take about 15 units in the NTTC and 2 subjects in the clinical epidemiology department. And many of them are already in positions in academe, assistant dean, department chair, and all involved in the education part of the training program.
So, ayun na yung multiplier effect na nangyayari from you to your mentees and to their mentees and the generation that follows your steps. O, di ba? I became privy of these achievements of the Chancellor when we interviewed him, because we're writing the history of NTTC as part of a heritage book writing project of our incumbent Chancellor. So thank you po, Chancellor Mon, for...
You were identified po as the rock star of... Tawagan kita ulit mamaya, sir.
So meron isang chapter tungkol sa inyo lang. Okay. So, salamat po. Baka kayo'y nadidiyan lang, and we're happy to also announce that as of the day this year, I learned that there are only 3 professors, ano ba plural nun? Professor Emeritus. Emeriti. Professor Emeriti among our MHPED alumni. You were the first, and you were followed by Dr. Magcasi of FEU and Fatima and Dr. Liberato de la Rosa. So tatlo lang kayong for the last 45 or so years ay doing MHPED work. Salamat po. Okay, so Denise, I read some
Yes,
questions. Thank you,
ma'am.
Chansey. Meron pa yata akong
Mhm.
nabasa mga katanungan sa chat box
Okay po.
natin. Wag,
Yes, ma'am.
oo.
Okay.
Thank you,
We'll
Chansey.
go back po, no? Thank
Mm.
you po, Sir Cadio. Ayan, so we'll go back po sa question kanina, no, ni Ma'am Sheila Trajera. So
Apo.
among the authentic assessments which you have introduced in your class, which do you think is the best po?
Okay. Ma'am, first of all, that the courses that I teach are in health professions education. So I am not a clinical faculty. I teach courses in research, or courses in research, instructional design, attitudes development program, and attitudes development and assessment and curriculum planning. In all of these courses that I teach, formatively, I make students go through the process of the designing phase. So if it's research methods, we go through the different stages in the research methods, in the thesis writing phases, and each step of the way, they really produce outputs. Like before everything begins in the research proposal, they have to review literature. So my first assessment is appraise a literature, appraise a journal in the most scientific way. And then after they have learned syempre they already familiar with appraisal of literature, then they start writing the introduction, writing the methodology, developing the research framework. May be very theoretical, but the authentic assessment is always produce your output, write your own, create your own research proposal from the definition of concepts all the way to the development of the research framework and the methodology. It's the same thing with my design courses. I teach instructional design, course development, curriculum planning and development, which I also mentioned the same course that Dr. Arcadio took in 1990. These are design courses and there are specific steps, best practice models that our class talks about. We get to know the different models of designing, and then in the end, the students do formatively real outputs as they go through the design phase. And then towards at the end of the SEM, the final output is a course design. There is no my students will say, meron nga kami midterm bukas eh. Syempre there should be a combination of assessments. Kasi, di ba, authentic assessment means that the students produce an output, but it should be reflection of what they know. So they should also learn, they should have a good grasp of the basics, the essential principles, and that's the purpose of the midterm exam. Okay, I see some of my students in the design class who are here right now. Baka makalimutan nyo ha, may midterm tayo bukas ng 1 to 3. But so it's just one of the exercises and I think it's just 15%. The bigger portion of the grade will come from the actual outputs that they will produce. I think, ma'am, sino na nga itong si Ma'am Sino nga yung nagsagot?
Trajera po.
No,
Ma'am Sheila Trajera po.
Oo, si Ma'am Sheila Trajero. Yun yung real authentic measure. What is it that the students have to come up with or to become after a course or experience with you? So, no shortcuts. That if this is the requirement that they will be course developer, then the course should teach them how to develop a course, and in the end, they should come up with a developed course. Yun po.
Okay. Ma'am Beng will read po the second question.
Beng, mute ka.
Nakamute ka ba?
Another question. Sorry po. Another question from Mary Joy de la Peña. Aside from applying the CHED CMOs, our health sciences schools generally implementing the equivalent of the AMA pilot programs that had granted $1 million grant to those schools po.
Teka muna, Beng. I didn't quite understand. So you're referring to the pilot schools
Yes,
and
ma'am.
tapos?
Aside from applying the CHED CMOs, how are health sciences schools generally implementing the equivalent of the AMA pilot programs that
Ah,
had granted a $1 million grants to those schools.
mm. Buti sila mayroong 1 million. Hindi 100. Did I hear you say?
1 million,
1 million
$1
lang,
million dollar.
$1 million grants from the 11 schools. The article that I cited to you, yung dalawa ng tungkol dun sa health system science ay naka-explain, naka-enumerate kung which are these medical schools. In the Philippines, we have several institutions, and within these institutions are several courses that have already been teaching health system science. The confidence is just that not that strong yet, because we didn't label them as health science system curriculum. Parang naimbento nila muna yon in 2010 na HSS, but we have been talking about health system science, and now it will be we have been integrating health system science in our courses. You will ask me, I can tell you one specific situation in the MAP MHPED program that we have in NTTC. I think February, shortly before classes started, we met all our students in the MHPED program, in the master's degree program. We oriented them on the rubric that we will be using for their capstone project. And one of the items that is included in that rubric is the capstone project being a reflection of nationalism, internationalism, and legal standards. Okay, and when I was asked by my colleagues in NTTC and our students, what exactly do you want to see in our capstone project? The capstone project may be a course, it can be an examination, it can be an infographic or a call for advocacy. And so I explained to them, we have to be consistent with health system science and the Republic Act 11223, that we are co-opting. Remember, I mentioned that HPED now is co-opting with healthcare delivery system, so that we want to see in outputs of our students a consciousness that they are addressing a particular health issue while teaching those who are in that field. So when I say there are reflections in the capstone project of internationalism, nationalism, we want to see certain yung palpable indications that there is consciousness to address the 17 Sustainable Development Goals. And it's not just SDG number 3. Okay? Kasi SDG number 3 is the only one that deals with health. But there are other SDGs, number 4, there are issues on education, issues on poverty, on equality. If your output is related or has some indications of these Sustainable Development Goals, then it becomes co-opting, HPED education co-opting with health system science. And in our own little way, we would like to say we have been doing this for many years already, and in all subjects. Okay? Yung isa pang tanong na I could speak for our courses in NTTC. Tapos I know I have some other colleagues in different professions and institutions that are doing the same thing. In fact, they are presented in some local and international conferences, and the innovations are almost limitless. We see them all the time. We just need to innovate.
Okay, thank you, Ma'am Erdy.
Si Joy de la Peña po. Hello.
Ay, Joy!
Hi, yes. From Southwestern University po.
I
Pinma.
know, from Pinma.
Ano po, makulit ako doon kasi nakakatinag yung $1 million grant per school eh. Tapos iniisip ko, anong ginagawa natin dito? I mean, the key phrase po sa answer niyo, thank you for answering, key phrase doon, in our little ways. So parang hinahanap ko yung, nabibigyan ba tayo ng budget? Parang ganun. na initiative, for the initiatives. But yes, in our own little ways po, yung yung educators mismo nag-change yung mindset, no? Yun lang po.
Thank you, Joy. I'll tell you.
Can I
Ah,
share something?
Sure. Sino yun?
Sinem.
Alin? Oo.
Sa innovation kasi, if you study, for example, innovation, meron tayong tinatawag na innovation and change sa education na pwede ka kasi yung ano mo lang, absorb mo yung innovation. Mabagal kasi yun eh. Tinatawag natin na natural diffusion theory. If you follow a natural diffusion theory, baka itong pinag-uusapan natin ni na Erlyn, baka retired na kami ni na Erlyn, wala pang umi-embrace niyan, di ba? Ibig sabihin, meron tayong tinatawag na natural diffusion. Parang sinasabing the kinder education took more than 100 years before it was embraced by US. So what government is doing is basically to do what we call parang gagamitan mo ng mga funding. Ang tawag natin doon ay parang, I forget the term. Pero when US was introducing, for example, the change to their science education as a result of the study on the nation at risk, when naunahan na yung US ng Russia, no? Because nakauna na si Sputnik. Nauna na si Sputnik, hindi yung bakuna. Nauna yung Sputnik na space, travel. Ano yung US, anong problema ng ating education? Which is basically, bakit nauna ang Russia? The thing is, parang siguro kasi maganda yung kanilang science education. Ang US naman ay nakafocus dun sa medyo social science at that point. So, ang ginawa, nagkaroon ng isang reformulation of curriculum. But the only way for it to be fast-track is to provide funding for it. Ibig sabihin, hindi basta mag-absorb tong mga medical school ng change nang walang kasamang support system. I remember no panahon ni Flavier Erlyn, di ba, nung nagtuon tayo ng PASE at saka ASE, yung Program for Alternative Health Science Education and eventually the Alternative Health Science Education. Kasama kami dun sa mga ibang project na kung saan nagbigay ng pondo si Secretary Flavier ng tigwa 1 million sa nursing school at medical school na mag-i-improve community-based education. Kaya ang daming, siguro naalala pa ni Sir Arcadio, ni Chancellor Arcadio, yung panahon na yun, ang daming school na nag-embrace ng community nursing, community medicine, kasi may 1 million funding bawat school. Nung nawala na si Flavier, wala na rin yung funding, wala na rin yung mga project na yun. Nagbago na naman ang sistema. Kailangan talaga nating, hindi po, totoo yun, baka itong pinag-uusapan natin, kung gusto natin mangyari ng mabilis, ay hindi itong sistema ganito. Kailangan talagang ang gobyerno, hindi pwedeng yung DOIs, labas ng ano yung nangyari mo earlier, Joint Memorandum Order. Labas ng DOIs yung Joint Memorandum Order. Babasahin ng mga school yun. Ano ngayon, gagawin ba namin yan? Lalo't hindi naman yan. So, anong kasunod niyan? So, we really need to provide that kind of financial mechanism to support innovation. Kaya nga itong nangyari sa UP, kahit paano napakabilis, kasi very supportive, panahon pa ni Dr. Arcadio, sinuportahan niya itong ganitong sistema. So, ibig sabihin, allocate ng, sige, NTTC, strengthen namin kayo, di ba? Ito mga support natin. So, mag-open tayo ng innovation sa medical education sa ating extended School of Health Sciences. Pero may kasamang pondo yun. Di po, yung usapan lang yun. Sige nga, mag-develop kayo, antayin namin kayo, ay baka retired na si, di ba? Walang mangyayari. So, unless school administration would really give fund to it, not just embrace it as a phenomenon or as a theory, but really support fund and CHED and Department of Health and all other involved stakeholders would provide fund, mababagalan yung itong baga hindi na uso yung UHC, bago na naman yung medical education. Ganun, bagal natin inaano ko lang, no? Ini-explain ko lang na yung sinasabi ni Early ng mga innovation. Ilang taon na kami, magpi-50 years na kami. Ngayon parang nagtatraction yung MHPED na pati hospital, nag-training na, pero we're happy with it. Pero ang bagal, di ba? Tagal. Pero at least nangyayari. Pero I doubt it kung walang pondo kung mangyayari yun. So, Sige, persahin natin yung ano. Mag-advocate tayo. Bigyan ng pondo yung ganito.
So, ano pa.
Thank you.
Okay, thank you po.
Yeah.
So, on the right track lang pala sa amin na bumubuhos talaga ng millions sa pagpapadala ng mga faculty.
May makalipat na dyan.
Sabi ko nga sa
Hindi totoo yung PINMA education kasi nag-i-invest sa
Diba, sabi ko nga sa Mr. President ng PINMA, Sir, kailan mo ko ipapadala? Kasi nagpapadala ka sa University of South Carolina. University of South
Sabihin mo,
California,
Joy, mas
USC,
matipid pag dinala sa NTTC
Lipat ka muna
kaysa sa UIC.
Ay,
Muna ako sa Southwestern. Ay, hindi na
naka-timing
lang
po ako.
hindi
May
na
mga
magpapadala.
students din. May students din kami sa NTTC po.
Oo, di ba?
I know,
Oo,
I know.